Wide complex tachycardia. Definition of wide complex tachycardia, WCT. Wide complex tachycardia is defined as a cardiac rhythm faster than 100 beats per minute, with wide QRS complexes, QRS duration of 120 millisecond or longer, in the surface ECG. Differential diagnosis of wide complex tachycardia. Irregular rhythms. 1. Ventricular tachycardia, VT. 2. Rate-dependent aberration or pre-existing bundle branch block, BBB, with any type of atrioventricular nodal reentrant tachycardia, AVNRT. Orthodromic atrioventricular reentrant tachycardia, orthodromic AVRT. Any type of atrial tachycardia, AT. Or atrial flutter, AFL. 3. Pre-excited tachycardias. Antidromic AVRT. Bypass tract AVRT. Pre-excited AVNRT, AT, or AFL. B. Irregular rhythms. AF or AFL or multifocal atrial tachycardia, MAT, with either aberration, BBB, or pre-excitation. Polymorphic VT, torsade de points. C. Paced rhythms. Pacemaker-mediated tachycardia. Pacemaker tracking of supraventricular tachyarrhythmia. D. Artifacts. In adults, VT constitutes about 80% of cases of wide complex tachycardia, aberration and BBB 15%, and pre-excitation 5%. In children, on the other hand, VT constitutes only about 5% of cases. The linking phenomenon, a mechanism of aberration. The linking phenomenon, also called concealed transseptal conduction, is the repetitive transseptal retrograde concealed penetration of a bundle branch, by impulses propagating anterogradely along the contralateral bundle branch. The linking phenomenon is the mechanism for perpetuation, continuation, of functional anterograde bundle branch block. If the impulse propagates anterograde in one bundle branch faster than the other branch, it can penetrate the septum and the other bundle branch retrograde. When the process is repeated each beat, it will render the other branch refractory to successive impulses, perpetuating functional anterograde bundle branch block. Causes of a wide QRS complex. Apart from wide complex tachycardia, other causes of wide QRS complex include abnormal ventricular activation sequences during sinus rhythm, such as occurs with bundle branch blocks, aberration, ventricular pre-excitation syndromes, nonspecific intraventricular conduction delays, and premature ventricular contractions. Pacemaker-generated beats. Ventricular hypertrophy. Electrolyte and acid-base abnormalities, such as hyperkalemia, hypermagnesemia, and acidosis. Hypothermia. Drug toxicities, such as occurs with tricyclic antidepressants, cocaine, phenothiazines, lithium, diphenhydramine, or other drugs having sodium channel blockade or quinidine-like effects. Artifacts. The diagnosis of WCT incorporates clinical findings, chest X-rays, surface ECG and electrophysiological studies, EPS. Symptoms. Some patients with tachycardia can have few or no symptoms, such as palpitations, lightheadedness, and diaphoresis. Others can have severe manifestations including angina, dyspnea, syncope, seizures, and cardiac arrest. Symptoms are caused by the fast heart rate, associated heart disease, and the presence and extent of left ventricular dysfunction. Severity of symptoms is not useful in determining the tachycardia mechanism. It is important to recognize that VT does not necessarily result in hemodynamic compromise. Misdiagnosis of VT as SVT based on hemodynamic stability is a common mistake. Tachycardia rate. The tachycardia rate is of limited use in distinguishing VT from SVT. When the rate is approximately 150 beats per minute, atrial flutter with aberrant conduction should be considered. With a ventricular rate faster than 200, suspect pre-excited tachycardia. Some useful differentiating clinical parameters are summarized here. Age older than 35 years, mostly VT, the positive predictive value is 85%. Duration of tachycardia. SVT is more likely if tachycardia recurred for more than 3 years. Underlying heart disease, previous myocardial infarction, 95% VT. Pacemaker or implantable cardioverter defibrillator, increased risk of ventricular tachyarrhythmia. Medication, antiarrhythmic drugs, QT prolongation, aberration, diuretics, hypokalemia, hypomagnesemia, digoxin, monomorphic VT, bidirectional VT, non-paroxysmal junctional tachycardia, antimicrobial, macrolides, quinolones, prolonged QT interval. Carotid sinus massage. Sinus tachycardia, atrial tachycardia, and atrial flutter, gradual slowing then acceleration upon release, but the arrhythmia is unaffected. AVNRT and AVRT, either terminates or unaffected. VT, generally unaffected, although this maneuver may slow the atrial rate, and in some cases, expose AV dissociation. VT can rarely terminate. Physical examination. Physical examination is of importance primarily in determining the severity of hemodynamic instability. In patients with significant hemodynamic compromise, a thorough diagnostic evaluation should be postponed, until emergency DC cardioversion is done, which does not require knowledge of the mechanism of the arrhythmia. Clinical evidence of AV dissociation. AV dissociation may be detected clinically in up to 50% of patients with VT, seen as intermittent Canon A waves in the jugular pulsations. AV dissociation is very rarely seen in SVT, it will be detected as continuous and regular prominent A waves. Fluctuations in blood pressure can occur because of the variability in the degree of left atrial contribution to left ventricular filling. Variability in the intensity of heart sounds, especially S1, may also be observed, particularly when the heart rate is slower. Laboratory tests. Hypokalemia and hypomagnesemia particularly predispose to the development of VT. Drug levels may be checked, for example, digoxin, quinidine, and procainamide, to rule out drug toxicity. Pharmacological intervention. Lidocaine can terminate VT, and infrequently AVRT. Procainamide and amiodarone can terminate both VT and SVT. Digoxin, verapamil, diltiazem and adenosine can terminate SVT and occasionally VT. Chest X-ray, look particularly for evidence suggestive of structural heart disease. Evidence of previous cardiothoracic surgery. Presence of a pacemaker or implantable cardioverter defibrillator. Approach to differential diagnosis. 1. Exclude artifacts. 2. Exclude pacing rhythms. 3. Surface ECG features. 4. Electrophysiological studies. Clues to artifacts. 1. Simultaneous ECG leads recorded, with artifacts seen in some leads, while other leads show the actual rhythm. 2. Presence of actual QRS complexes within the artifacts. 3. Very rapid non-physiologic rates, for example, faster than 400 per minute. Pacemaker-mediated tachycardia, PMT. Pacemaker-mediated, also known as endless loop tachycardia, may occur in patients with pacemaker with atrial sensing, when a ventricular impulse, either paced or spontaneous, results in retrograde atrial activation, and the latter is sensed by the atrial electrode returning to the ventricle after an appropriate AV delay. A paced ventricular response follows, and the process repeats itself. This arrhythmia is discussed in detail with cardiac pacing. Thank you.